Good morning, everyone, and welcome to this webinar from the Behavioural and Implementation Science Intervention Center at the Yong Loo Lin School of Medicine. My name is Joanne Yoong. I am the founder and CEO of Research for Impact and also very proudly a faculty member of BISI. I'm delighted to have us all here today this morning to discuss population health and payment models, what we can learn from behavioral implementation science. Today, I'm also thrilled to have with us two eminent speakers who will be giving us their perspectives from two different sides of the world. First, I'd like to welcome Prof. Chien, the Deputy Group CEO of our Regional Health System for Sing Health. Chien, thank you for being here with us this morning. Prof. Lee leads population health efforts in Eastern Singapore, and he also chairs the planning committee for the upcoming Eastern General and Community Hospitals. Previously, Prof. Lee has been CEO of Changi General Hospital and Deputy Director of Medical Services for Health Services and Healthcare Performance in the Ministry of Health. He's also an adjunct professor at the South Swee Hock School of Public Health, Duke NUS, and the Singapore University of Technology and Design. So thank you so much for being here to give us this perspective from Singapore.
Most happy to be here.
Our second speaker today, I'd like to welcome Dr. Don Ali, an expert in population health and healthcare from the United States. Don previously led healthcare innovation at Morgan Health, JP Morgan Chase Business Unit, focusing on employer-sponsored healthcare. Prior to experience at JP Morgan, Dawn was Chief Strategy Officer at the Center for Medicare and Medicaid Innovation, where she led the investment strategy across a portfolio of value-based transformation and population health models. Dawn was also, before that, a senior advisor to the Office of the Surgeon General. She's also been an academic, going through the University of Maryland School of Medicine, and currently an affiliate faculty at the Milken Institute School of Public Health at GWU. And recently, Dawn has moved into a new role as President of Decision Support at Cambridge Health, which I hope she'll speak about later as well. So we welcome Dawn here with us today as well. Thank you, Dawn.
Thank you, Joanne.
So I'm going to actually get right to it. This is a webinar that we have all been looking forward to, as Singapore is moving forward very rapidly in its transformation towards focusing our healthcare system towards population health at a level that we haven't seen before. In terms of Singapore's healthcare transformation journey, this is not a new step in concept, but very recently, our announcements about Healthier SG and payment models that might involve quite a radical change in the way that we think about financing to move towards a capitation model at various levels of the healthcare system has left many of us asking questions. And so without belaboring it further, I'm going to actually invite both Chien and Dawn to give us a little bit of their perspectives on where we see population health from a Singapore as well as a US perspective. So Chien, could I just ask you to kick us off this morning by speaking a little bit about how you see this journey towards population health from a Singapore perspective?
Okay, thanks, Joanne, and thanks for the opportunity to be on this webinar. I think as you have highlighted, the population health journey is a multi-year journey. It's not something that just came up, but it's from the structural perspective and from the how we organize ourselves to the focus and the efforts that we have put in place. I think it is layering on efforts that are already ongoing. So, and I think one of the key push for it is actually to focus more on upstream prevention and also to align the incentives for both the provider as well as the funder and hopefully also for the residents. So I see the move towards population health as, initially when in year 2000 in Singapore, when we had the 2 healthcare clusters, it was 2 vertically integrated, but made up of mainly public sector institutions. Then in health, when we moved to the Healthcare 2020 Master Plan in 2012, and as a result of that, we came up with the 6 regional health systems. It was to enfold the patients, hopefully taking care of them at home. And now that we move to Healthier SG, it is moving, not just looking at patients, but looking at the residents, and which includes those who are still well and hope to keep them well, and those who may have been part of our system but may have been lost to follow up, and also those who are currently in our system. So I see that by this progressive expansion, in a sense of the focus and the emphasis, we are really trying to take a more life cost approach for the various groups of our residents, understanding that for our residents at different stages of their lives, they may have different priorities, different values, and we have to respect that and work with them. And the second important part is the need to work with partners, because as we go into, when you speak of health rather than healthcare, as all of us know, it is the social determinants of health and the other determinants of health are equally as, if not more important than what just the healthcare system itself can deliver. So I see this, and I think one of the key changes, while we have mentioned capitation, I think one of the key changes beyond just capitation is this assignment that each of our 3 regional health systems have been that assigned a population that we are responsible for. Even if they have not touched our system, we need to see how can we meet their needs as well as meeting their aspirations. I think I'll hand over to Dawn and I'll jump in later. Yeah, thanks.
Great. Dawn?
Well, thank you. This is such an exciting moment to be having this conversation. And, in the US, population health has meant many things. The framework that resonates the most with me and that I think has been the most transformative is really to think about the health of a whole population, geographically attributed in the way that Professor Lee mentioned. And the way that we think about that is the health outcomes of a group of people, including the distribution of outcomes within that group. So essentially trying to improve the mean, the average, and close the gaps, narrow the health disparities and unnecessary variation in treatment. Practically, we have not achieved that in very many places. So the vast majority of the US health system, when we talk about population health, is talking about an attributed panel of members that really relates to value-based payment, another topic I know we're going to talk about quite a bit here, where a provider is taking responsibility for a set of patients that have typically been attributed because that's the provider that they see most frequently. And in a theoretical world where every population member is attributed to some provider, you can get to that level of full population coverage. But again, in the US, we've not gotten there very often. So typically what we're talking about is a provider trying to do something like control hypertension or address social determinants of health for their particular panel of patients. And we have a few places, most notably, I would say the states of Maryland and Vermont, that have managed to take a much more whole population approach to payment and to accountability for transformation. So excited to talk more about those.
Okay, thank you. I actually should mention as well for the audience that I will be taking questions on the side. So please place your questions for our speakers. I know many of you out there do have questions. We will be consolidating them and weaving them into the discussion as we go along, and we'll also open for Q&A at the end. So please feel free to start asking as well. So I am hearing, I think, in both of these conversations, very similar elements. We're talking about more holistic care, the entire care pathway. We're talking about a whole population approach. And we're talking about what that means in terms of bringing person centricity, I think, to the process. We're talking about meeting the patients where they are both geographically and in a very real sense with respect to their culture, their beliefs, their practices, and their needs. And we're also talking about a different healthcare culture that here I think means that we have to be more inclusive, more creative, and I think as Chien also mentioned, more collaborative. We have to seek out partnerships. And all of these things are new for us, or not new for us perhaps in spirit in Singapore, but in terms of formalizing this into the design of care models. Chien, I would like to ask you, in your role, both as a very eminent practitioner and leader in the healthcare space, what are you thinking of first when you think of designing these new care models? What are you thinking of in terms of measuring and managing population health in Singapore?
Okay. I think, as you highlighted, it is important for us to start with the end in mind. And if we look at measuring the healthcare system, I think we have been, and the Ministry of Health also has been discussing with the respective clusters as to how can we monitor our progress and how do we know how we are moving towards it. And I think we have, in a sense, adopted the framework that OECD had used, where we measure it in terms of 4 different types of indicators. I think at the highest level, it is the health status and the cost of healthcare. Because when we move to population health, it's not just on those who are using, but also the total system's cost, not just from the provider's perspective. The second group of indicators we look at are the risk factors. And that's where we measure both the lifestyle risk as well as other potential social determinants. And the third one, which is, I think, most relevant to healthcare providers and institutions, is the health system's performance. How are we doing in terms of keeping our people healthy, meeting the needs of those who are sick, and then including all the way to end of life. And the fourth set of indicators are the contextual indicators. Because, for example, this will be the demographic indicators. Because if we are comparing between, let's say, different countries, we will need to look at what is their demographic profile, socioeconomic status, and things like that. So I think those will be the 4 big sets of indicators. I think the devil is in the details as to, if you were to ask me what are the specific indicators, I think I would say these are still works in progress, especially those related to how do you measure the social determinants of health. But I think, and at the end of the day, I think the 2 key goals are, in a sense, how do we promote well-being and delay disease? So from a public health physician perspective, it is the 3 types of prevention, primary, secondary, and tertiary prevention. And then the second is to optimize the outcomes for existing patients. So I think we will come back to the themes and unpack them in greater detail.
Great, thank you very much. And I think that gives us a great frame. I'd like to actually move that over to Dawn and ask Dawn, just in terms of the perspective from the United States, how would you frame that? Especially in the population models you've spoken about, for example, in Vermont, is that very similar, or are there radical differences?
Well, I think you're exactly right that the devil is in the details. This is just an incredibly tricky area. And most of the population health models, for example, in Maryland and Vermont, have been trying to get at the idea of longitudinal accountability, meaning a provider being accountable for what happens to a patient over a 12-month period, which is very technical. But what we think that unlocks is that it means that if I'm a primary care provider, it's now incumbent upon me, if I'm accountable for outcomes over 12 months, to have a mechanism for coordinating with specialists. If I'm a hospital, I need to have a way of coordinating with primary care and kind of creating those incentives for a real focus on the patient's experience across settings, as well as their day-to-day life in the community, which takes you to social determinants of health. How to roll that all up into a small group of measures is incredibly challenging. And we've tended to use measures like avoidable hospital admissions, those that we think could be avoided through improved primary care, as a major focus area, as well as some measures that are focused on chronic disease prevention and management. So really trying to move in this direction. Excuse me. But it's very challenging to move from that health system level to, excuse me, to the total population, level, and capture all the variability that you want to across specialties and populations. You mentioned the life course perspective earlier, and how do we measure the right care for different age groups? What I think we have found, again, particularly when we look at value-based payments, is that fewer is better, that we need to have a small group of measures that providers can understand and focus on and optimize around, that when in one of the major value-based payment programs in the US, at one point, there were 32 different quality measures, and they were all important. They were all important, either outcome measures or process of care measures. But of course, it's impossible for a health system to focus on improving across 32 areas at once. And so one thing we found in evaluations is that it works much better if we can focus on a few priority areas. So as one example, the state of Maryland selected diabetes as a major priority area, actually built that into the financial models so that it's a little more complicated than this, but effectively hospitals in Maryland get a bonus if the overall incidence rate of diabetes in Maryland goes down. And so that creates this very strong incentive for hospitals, which are normally focused on much more downstream consequences of diabetes, to really be investing in upstream prevention of diabetes. So those kinds of very focused goals we found can be more effective.
Yeah, and I think that's really fascinating, because I think, and also some of the questions that we're getting in the chat are really about how, as we're going through this transformation, we want to have a wide dashboard that is very inclusive and generalist, but at the same time, we need to not have literally hundreds of indicators or ever-changing indicators, and having thousands of indicators that don't necessarily measure the right thing is very difficult. But curating that down implies a lot of trade-offs that it's very hard for us to make. And I'm also hearing that we need, firstly, these coordination mechanisms to be strengthened, information systems to be strengthened. And I think that takes us actually very nicely into our next question, which is really, let's talk about how in these models, payment, care models, incentives, and change management, cultural management on the ground are all going to have to move together. So maybe, Chien, can I come back to you and ask you, and I think also in the Q&A, we're having some questions now about healthier SG. When we bring these models to the ground, especially with our GPs and our primary care, which involves a large numbers of GPs, as well as when we look at our hospitals, which are trying to move towards a more holistic, generalist approach with multimorbidity, how do you think we should be looking at this kind of change management and incentives and payment?
Okay. Firstly, I would like to distinguish between assignment and enrollment, because I think sometimes there's a bit of confusion there. In terms of assignment, each of the 3 clusters in Singapore is assigned geographic residents within a geographical location. So, and the capitation budget is based on that assigned population. So, for example, like for SingHealth, we have been assigned a population of 1.48 million. And we are accountable for this 1.48 million residents. And in that sense, we have 3 roles: the service provision role, the population health manager role, which is accountability for this 1.48, and the regional health manager role, which is about building the ecosystem with our primary care providers, with our other partners in the community to achieve what the outcomes that we desire. So those will be the 3 roles that we are doing. And when the budget is worked out, the capitation budget, it is based on the number of people. There will be some age adjustments, but that will be, in a sense, and also there will be some out of cluster transfer, because in Singapore, we are quite small and there will be some movement. So there'll be some adjustments there. But by and large, our, in a sense, the accountability as a population health manager is for the assigned population. So that requires a significant paradigm shift or mindset shift, right? Because and this, I think, is an effort to align the incentives for the providers from a fee-for-service system to a more, as is highlighted, a more holistic system where we are, in a sense, incentivized to work more towards upstream preventions, and also to collaborate with partners. Because with the budget that we have, if we try to do everything ourselves, one, it is not feasible, and two, even if the budget grows, we won't have the expertise and the capability to do it. So it is essential for us to collaborate, and that's where the working with the primary care providers, the GPs, and therefore under the Healthier SG strategy, one of the key components is to mobilize our network of family physicians, and at the same time to get our patients to enroll with a GP to build that long-term relationship. Because we do know that for many of the chronic diseases and to keep it healthy, a lot of it is very relationship-based. And because we need to build trust, and we need to get, to listen to our message, it needs to have that. And because a touch and go approach works for maybe episodic care, and if you have acute appendicitis, that may be appropriate because you don't want to stay too long and it's just done. But for chronic disease management, we need to have that longer term relationship. So I do see that in a sense, there will be then necessary to have incentives for the GPs as well as for the patients, is how to make this work. And this is an ongoing conversation, because we do recognize that there are various pain points or obstacles that need to be addressed. And I think it has, from the consultation, some of the big items that come up include things like the differences in drug prices. So if the price is higher at the GPs than even in our specialist clinic, patients, the financial gradient does not incentivize the patient to move. We also need to work with employers and see how they can, encourage their staff to work with the resources. Because just at the meeting yesterday, when someone commented, it says, I have built my relationship with my GP, but each time we change insurers, I change the GP changes. So how do this work? So it's both a cultural change as well as I think a structural change that we need to put in place for all these bigger components. And as you have highlighted, a key enabler would be the information systems, because if we are to work together, then we need to be able to share information securely and in a timely manner. And this is going to be an essential element, because one of the biggest bugbears that many people have is, one, I don't know what the other provider is doing. Another bugbear is it just takes too much effort to submit the data, to key in the thing. So how can we make it as seamless and, in a sense, as customized as possible? Because for our primary care providers, they don't need the EMR system that the hospitals have with all the high functionalities, but they need one which is fit for purpose. So I think while we think big in terms of the implementation, we really have to think of minimal viable products to get us going, and also the fit for purpose things, because this will then make it more sustainable for the whole system.
Yeah, absolutely. And I think the MVP proposition is not just about being sustainable, but getting people to sign on even at the beginning. I think we do have a great vision of what things could ultimately look like, as you say, but I think driving these incentives down to the ground level is going to be the big question. And I'll come back to that again when we talk about implementation, that we can set a lot of things in motion, but how do we get that to the real ground for the physician at his desk or her desk? That's, I think, a very big question for all of us here, and I think for many people in our Q&A. So Dawn, I think also, as we've been talking now about value-based payments, what could you share with us about some perspectives from the experience of the United States about value-based payments in a population health setting, which again, I think is a question many of us are asking today?
Well, I want to say, I think you are starting from such an exciting foundation. You have universal coverage. Unlike in the US, you have about 60% of your physicians are non-specialists. Ours is the reverse. So when we're talking about prevention and primary care, we're already sort of fighting an uphill battle. I know it's not perfectly complete, but you have an integrated health information system that is working across all of your public providers. That's an amazing place to be starting from. I think some of what I've learned, and certainly we've seen in the US, is about the issue of cultural change, which you mentioned earlier, and the need for those early adopters and those real champions. So something that I think most CMS evaluations of different value-based payment programs showed was that inevitably we had a group of providers, could be hospitals, could be physician level providers, where we would have a real leadership champion who was totally bought in and ready to go. And then there would be, another group that was either sort of kicking and screaming, coming along with the change, or had like maybe one, leader who was excited about doing it, and then that person left and things sort of fell apart. And I would just say that one of the things that we found again and again was that it's not just about incentives. We sort of started from a policy perspective with like, we have to get the incentives right. And that was true. But we also needed to sort of like build the quality improvement and patient focused muscle to be able to use those incentives to actually transform. And that cultural piece was really important. At the same time, I think we also saw again and again the kinds of change this could unlock. And I'll share an example from the accountable health communities model, which was focused on social determinants of health. But this example is very typical, I think, from many quality improvement initiatives over the years, where in the accountable health communities model, participating sites were required to ask every Medicare or Medicaid beneficiary that came through their doors about a set of 5 health-related social needs. So these were things like food insecurity and housing affordability. And one of the things we first heard from sites was like, our patients don't have any of these things, or the ones that have them, we know, like we've been working with this person for years. We know she's on Medicaid, and we know that she has a lot of psychosocial issues that we've been supporting her on. We also got like, we don't want to ask the question because we're not sure we can solve the problem, like just all sorts of barriers and questions about whether this was a good idea. And then what we saw, and eloquently put from a clinician who said to me, when you know better, you do better. But what we saw was that, of course, these issues are widespread, and that in many cases we heard from providers saying, I never knew that so many of my patients were dealing with food insecurity, and I'm so glad I'm asking them now. And now we have a program that connects them with community resources. Or, I had no idea the amount of violence, intimate partner violence, elder abuse that my population was experiencing. And I'm so glad that I now have the resources to get them connected with services. But all of that took like the biggest inertia was just getting started. And then people saw the value once they had the information. And that information was helpful not only to individual practitioners, but also to regional health planning efforts once we had good data on the social needs that patients were experiencing and could really match that and begin to design interventions around it. So I think, you can't separate the data piece from the value-based payment piece, but when you can bring both together and do the cultural work, you can really unlock transformation.
Perfect. Thank you, Dawn. I'm going to go back to Chien, and I think we have a couple of questions in the Q&A as well about specifics around the design of these things. And I think there are still 3 areas of questions that we're seeing. One is at the various levels within the RHS. Number one, how do we really see resource allocation, people thinking about resource allocation and setting those incentives across providers? Another question I think that's coming up is that there's a general, I think, concern in the Q&A about what happens when we focus our attention on costs. What kinds of mechanisms can we put in place to ensure that if we incentivize very powerfully cost reductions, we maintain quality? And I think this is in line with what Don has mentioned just now, which is that we start with the financial incentive model, but we need all of these other pieces to be built around it as well. And I think many of the concerns that we're seeing here about the incentives are really about whether or not at the end of the day, in a very specific worry is here that, we may end up focusing too much on cost to the expense of the detriment of quality. And then secondly, on the other hand, I think that perhaps we expect too much. And if we don't see reductions in cost, this may be something that people feel or people may not have realistic expectations of what happens around having that cost indicator not move. So could I just ask you, Chien, and again, as you're approaching sort of redesigning these incentives and and we just talked about all of these different measures into your population health dashboard, so to speak, how are you thinking about balancing all of these incentives across providers and then between cost and quality?
Okay, thanks for the question. And I think one of the key perspectives that we need to take whether we look at cost or quality is the time frame, right? Because some of it will be a real cost that we incur. Some of it will have to be considered as investment for the future, and some of it will be really and part of this investment. Some of it will be more like the research type, where we are not really 100% sure that it will generate the returns, but it's like any investment, something that we're trying out. So, and I think when we look at cost, it is also looking at whether it is a total systems cost or per capita cost. So, in a capitation-based system, I think what we are really looking at is, can we reduce the per capita utilization and the per capita cost for the majority of the population through better care and through earlier interventions? And I think that is likely to be a more realistic goal rather than just an overall reduction in total cost. Because as the population ages, we know that costs will go up globally. The input materials, the cost will go up too. So I think that the key challenge for us is at the individual level, can we reduce the per capita utilization? But I also see a question that rightly pointed out that for a specific group of the population, in fact, their per capita utilization may go up. And this may not be bad, because it could be those who have been have some already risk factors or already have quite significant disease, but was not picked up earlier. So in our initial effort as we move into population health, and as we screen and we bring these people into the system, obviously their healthcare costs will go up. But what we hope that as we go into this process in over the years, and therefore it is a multi-year project, and the number who we need to then detect that has significant disease that were previously undetected will actually decrease. And we reach a certain steady state where we have we can then seriously work on the reduction of the per capita cost. Now I come to the quality perspectives. I think as Don has rightly highlighted, the focus is on value. So even as Singapore moves to healthier SG, we talk about capitation and those, we shouldn't forget several years ago in 2017, we had the 3 beyonds, right? And one of the beyonds is beyond quality to value. So I think value is and continues to be a key driver of it. We shouldn't be looking only at cost, but at the quality. And therefore, for healthier SG, even as we are working on the financial perspectives, there is significant work on how can we improve the care for our residents. And one of the key initiatives that we are working on is how do we develop a care plan for each of the residents. And in SingHealth, what we are trying to do, and I think the other two classes are the same thing, is developing a single care plan. Because the challenge for many of our patients and residents is they have a care plan, but provider A has one plan, provider B has another plan, and sometimes it creates confusion. And when they don't comply, it may not be because of unwillingness. It's just because we have either given them too many things to do, and they just get confused about what needs to be done. So, and in this care plan, we are working that there will be two components. One is, say how we call it, a happy plan, which is the health action plan personalized for you. So, and this is where it looks at the preventive elements, the exercise, the diet, not smoking, and all those things. And for those who have already some illness, a chronic disease management plan. So, and how do we then marry the two into one? And that, I think, is where the quality side comes in. And at the end of the day, I think that's why the measurement, the matrices that we use to measure progress is important. If the matrix just looks at cost, and even when we use cost, we use the wrong measure. But if we use the correct measures for cost and also balance it with quality, I think with both, it gives us a more realistic view of what we can achieve. Because I think one of the key concerns is that we tend to swing from one side of the pendulum to the other. Yeah. In healthcare, it's always how do we maintain the appropriate balance of both the cost and quality. Therefore, I think the value conversation is going to be very important. Yeah, thanks.
Yeah, and I think keeping that balance and being sort of very pragmatic at the same time. I think healthcare is all about, I think, maintaining that idealistic vision, but being extremely pragmatic about where we're starting. And speaking of being extremely pragmatic, I think we have a couple of questions also in the Q&A, just about capitation in general that I'd like to turn to Don. And I think someone, in the chat has also sort of raised the question, do we actually have compelling evidence that capitation leads to, or is there any sort of compelling evidence that capitation leads to improved care and improved outcomes? And under what circumstances might we see that?
Such a great question. And I think we do have some evidence. Whether it's compelling is probably in the eye of the beholder and varies by circumstance. So to the point that you just raised, when we're talking about value, we want like more health per healthcare dollar, right? In some fundamental way. And just moving people into capitation is not necessarily going to get there. There are a number of programs that have attempted in the US to move to capitation with some strong tie to quality. I think we have some evidence that some of those programs have resulted in reductions in utilization per capita, things like fewer hospitalizations. Maybe most notably from a US perspective, where we're quite interested in trying to spend less over time, even where we have seen reductions in utilization, we have not always actually seen reductions in total spend. All of which is to say that we are actually spending more even as people are using less. And part of that has come from the complexity of capitation and the opportunities for risk adjustment. So of course, we want to make sure that we are appropriately compensating providers or health plans that are taking on very complex patients who are more likely to be hospitalized. We're going to pay providers or plans more for those members than for a member that's likely to use less healthcare. But what we've seen over time is that incentivizes very strong focus on documentation so that you can show, look, this patient is very sick and thus I deserve to be paid more for treating them. And so what we see over time is this sort of, actually, it doesn't take that long. Very quickly, we see an increase in the documented prevalence of chronic conditions among individuals in capitation, which leads to this increase in the capitation rates over time. So that's like somewhat technical. I hope everybody stayed with me there. But the point being that we have some evidence that when we have an entity who is at risk for total cost of care for an individual over 12 months, and where they have a reward in some way, lots of ways that you can structure that related to those members receiving high quality care, we can see reductions in preventable hospitalizations, improvements in chronic condition management. But at the same time, we believe there's good evidence that some of that is quite real. At the same time, we can also see costs continue to go up because of the challenge. And actually, the Center for Medicare and Medicaid Innovation in the US has seen this in the vast majority of its models. So in multiple models, it's decreases in costs, primarily typically driven by decreases in hospitalization rates, but without a net decrease once the various provider incentives were factored in. In other words, we sort of like overpaid providers for the improvements, with the result that the Medicare Trust Fund actually spent as much or more. So multiple examples where we've been able to decrease utilization or get some slight quality improvements, but very rare that we've been able to do that in a way that actually also bends the cost curve.
Yeah. So Joanne, if I may jump in, I think in terms of when we look at evidence for capitation, I think there are also, as Don has highlighted, potential confounders in the studies, because it is not just capitation as a concept, but also how it is implemented and how deep does it actually go. So in terms of depth, I will characterize it as depth at the macro level and the depth down to the micro level, because I see from some questions, one question was, we can do capitation at a high level, but what does it mean to the staff on the ground?
Yes.
Because we may have indicator that says reduce average length of stay. But if we just pass that same indicator all the way down from the CEO to the most junior, say, nurse or the allied health professional or the doctor, it'll be like, so what do I actually do? Right? So we need to translate it every step down and say, okay, if you're reducing this, then this is what you could do at the head of department level. This is what you could do. And that is going to be a critical step in this, and therefore there's needs to be a lot of conversations, dialogues, trying to understand that change management process. But at the macro level, it is also about who are involved in this change process. Is it just the healthcare providers, the healthcare sector, or is it going to be a whole of government approach, a whole of country approach? So I think in Singapore, the way we're approaching Healthier SG is really a whole of government, and in a sense, a whole of nation approach, where we are involving the public, the private, which is mainly the GPs, as well as the people sector, our NGOs, all those things, and the various other ministries are coming in order to see how can it, because we have been having conversations with our sports agencies, and in our discussions, for example, with sports SG, it's not just about for the elite athletes or the usual, but also how to get the more elderly be active. Our health promotion board, but that is within Ministry of Health, is doing it. Our People's Association, how do they have many activities in their community centers and things like, how do we leverage on it? So it is in a sense everyone trying to pull in the same direction and trying to achieve it. Because another element in population health is not just what we do in terms of outreach and health interventions. It's also improving the living environment, because that is one of the key contributors. And that requires many agencies out of healthcare. And again, conversations are going on, discussions are going on as to how can we do it in that aspect. So I think when we look at evidence, it's also we need to see how is it implemented, how deep is it, both at the macro, meso, and the micro level.
Thanks, Shannon. I think actually, so that actually answers, I think, the next question that we had in the discussion, and we've been talking about it, I think, throughout, right? Which is that the implementation is a whole other process that we have to manage on top of the design, and that it's going to require, firstly, a lot of conversations across stakeholders that might not have had that type of conversation before. It's going to require a level of detail and granularity that we have to commit to, even though we may not have all the information at the start. And I think we have to, also acknowledge what we've been talking about here, which is that we have to have a lot of clarity about when we can expect to see what type of changes, and that bending the cost curve in a very gross way is not necessarily the goal of Healthier SG, which comes hand in hand with capitation, and that capitation alone in its own sort of world is not actually what we're discussing here in Singapore. We're discussing the combination of Healthier SG and capitation. But again, the devil is really going to be in the details, and implementation is going to matter a lot. Maybe I can turn actually this back to Dawn. And Dawn, I'm going to ask, we are a Center for Behavioral and Implementation Science. So this is a time that's actually very exciting for us as well. And one of the things that we're sort of really interested in is thinking about behavioral insights, behavioral science, and implementation science to try to sort of use this as a tool. This is a moment in which we're really sort of facing many, many changes in a very complex system. What do you think we could do to use behavioral and implementation science, or how have you seen this used? Actually, we've talked a lot about evaluation and how important that is. Prospectively, how can we use behavioral implementation science? And, what kind of opportunities do we have here for research to play a transformational role?
Well, so something that we've seen that's a huge opportunity for behavioral and implementation science is related to helping providers succeed and use evidence under either capitated arrangements or value-based payment arrangements. So some of what's happened with capitation and value-based payment in the US is that it has led to a ton of vendors who come forward who say, I will help you manage your patient's diabetes. I can help you. I can be more effective at supporting nutrition or helping with any number of health behaviors or transitions of care. And providers not always feeling confident about where they should be focused or how they can effectively address issues like, say, medication adherence, which we know is very complex and not as easy as saying, okay, here's the prescription, but really requires a ton of health literacy, understanding on the part of the patient, potentially ongoing exchange or monitoring, all sorts of things. And so I think providers often feel very overwhelmed by that. And one of the frustrating things that comes from that is that even when we see very effective interventions, at least in the US, it's often been very hard to get them to scale. So, published results and then limited uptake. And so I think there's a tremendous opportunity to be able to take some of what we're learning in behavioral science and make it actionable for providers who want to do the right thing for their patients. Another issue that's been a huge area of focus is around variability in care. So in the US, whether a woman with a low-risk pregnancy ends up having a C-section can vary. Her probability of having a C-section can vary from as little as less than 20% to closer to 50%, depending on the hospital that she goes to or the provider that she sees. That's just one example, but on most metrics that we might look at, we see tremendous variability across providers and a lot of interest in how we think about bringing all providers up to, the level of guidelines and really getting to a rate of adoption of high quality evidence-based care that will make the whole system more efficient and also deliver better outcomes for everyone, but requires this real focus on, again, how do you get what works to the people who need it most? That doesn't necessarily happen naturally. It takes real effort within system design and quality improvement initiatives.
Right.
Yeah.
And then maybe I can turn that back to you and ask you again how, and I know that you also sit this place between research and practice. How do you see this informing each other, especially, behavioral science with relation to lifestyle change, I think, and physician behavior, as Don has sort of alluded to as well?
Yeah. Okay. So I will characterize it in a few points. Firstly is to distinguish between framework and what is rolled out at each stage. Because I think in terms of implementation, one as both Joanne and Don has alluded to, sometimes there can be too many moving parts. And when there are too many moving parts, if one part is, if we don't get the outcome, then we are stuck as to what is the cost. And we spend a lot of time troubleshooting, a lot of energy doing it, and we may not be actually getting anywhere. And in fact, it may be more a Brownian motion. And I'd like to take the example of, like Peter Sengi's, the double loop learning. We need to look not just at our outcomes and our strategies and tactics, but also the assumptions that are underpinning it. And we need to be able to define what these assumptions are, discuss them, and also challenge them. When things don't work out, is it our strategy or tactics, or is it our assumptions? And that's why I think in Singapore we have a conclusion that there are certain things, while we are making a broad-based change, certain things will still remain status quo. So one of the things that was assurance given is everyone will be no worse off from what we are today. So I think that's a great assurance, because sometimes when new measures are introduced, it is in a sense a euphemism for cost cutting, but giving the assurance that you'll be no worse off. In fact, there will be some additional funds being given for new initiatives. I think that gives the assurance. And also, I didn't answer the earlier question on resource allocation. The parties that have been managing the funds, most of them will continue to do so. For example, the Agency of Integrated Care will continue to manage the funds for the CHARS and those few things, because if one is for the clusters to take on this role, we need to build up our capabilities. Secondly, they already have that relationship. So in the midst of uncertainties and new things happening and great change management, I think it's useful to have some things that still remain familiar, things that still, that the relationships that have been there, to see how we can preserve it. So I think the first part is reduce the moving parts. And then the next part, you were speaking about evidence. Yes, I think that's the one key role that we need to do. But it is first, so I see in population health is about moving the needle at the national level. Because quite often we have programs that are effective and show good results, but they actually may touch only 5% or so of the population, or even the groups of people within that disease, right? So it may be a very effective program for diabetics, but if only touch 5% of diabetics, it's not going to move the needle for them or for the rest. So what I think is important is for our to translate the evidence into actionable items, what we call services, and from the services to then be able to scale. And scaling means finding the right channels in terms of scaling it. Right. So one of the examples is I think for what our KK Women's and Children's Hospital did for early childhood education, that they had a program that looked at how to help our kids to thrive, and they generated the evidence for it. They translated it into things like a curriculum. But the channel was not within healthcare. The channel was with ACTA, early childhood, which turned it into the Kids Start program, and then it spread. So I think we need to think more and more along those lines, that our focus is not so much in delivering programs, but about meeting needs. And I think that brings me to the third point, which is the mental models that we need to adopt and adapt as we go forward. Because although it sounds simplistic, but I think it's a lot of rewiring to move from delivering programs. Because in terms of when we do a program, we are very clear. This is what I do, as Don said. Yes. Nutrition, this is. But when we say meeting the needs and make it more person-based, that is going to be a challenge. And one of the key also mental models is population health does not equate only community health. I think sometimes when people hear the word population health, they say, oh, okay, that's what you do out in the community. Our hospitals must get involved in population health because we manage across the life course, across disease complexity. And for complex cases, the best place for them is still in the hospital, and the research that they do there is still going to be critical. So, and I think the final thing is how we look at our community. We adopt the asset-based community development approach, where we view our partners as assets and as creating the communities of possibilities.
Thank you, Chien. And I think actually that took us very nicely into the last question, which I had, which is about really what are the role of all of these partnerships and the different types of roles that different stakeholders play. And I think you've been very clear in sort of saying that also this is also about identifying the right place, the right entity, the right place, the right time. We want to look for how we can improve low value care. And sometimes that nexus is also between the healthcare system and other systems in a more holistic way. And that's where we need to look in a more broad sense to make this work. Maybe I'll sort of turn our last question then to Dawn, which is again to also maybe give us your views on partnership. And from the United States, what kinds of partnership do we need? And your particular background, I think, is so interesting. You've seen care models from so many different perspectives. How do we bring in partnership, particularly from the private sector and community organizations, to really make something like this go and to bring innovative ideas to the table?
So ultimately, we just have to hold hands and jump, right? And so we have to identify who the people are that we're going to engage in those partnerships, and we have to have good leadership. And, one of the ways that has happened in the US is by setting targets around value-based payment. Under President Obama, Secretary Burwell at the time set a set of targets around what the administration wanted to see related to population-based and value-based payments. What was really important there is they defined that for each part of the healthcare, each type of healthcare payer, including employer-sponsored insurance, so including private insurance. And they said it's not going to be enough if we only do this in Medicare and Medicaid. So, hey, private insurance, we want you to hold hands and jump with us because we think that we will only get the effects that we want to see if we are changing this across, the whole system. It's taken a very long time, so I don't want to make it sound like that was like a light switch that turned overnight. But I think, we really are seeing that and seeing more orientation toward population health across payers, which has been really central. I also am always mindful of the incredibly important role that community organizations and that policies and systems and environment play when we're talking about population health outcomes, and just how little about population health happens in the doctor's office or in the healthcare sector. I think if you want to unlock those kinds of partnerships, it does take a real goal setting process to get to an aligned set of goals to maximize community impact, because you can get everyone around the table, but if you're not getting them around the table with a clear goal in sight, it's very hard to actually get to catalyzing action. So I think we've had a few projects in the US that have utilized kind of a collective impact approach and said, we're going to all work together toward these very defined goals. And that those have, again, been hard. None of this happens overnight. So I think all the questions about what's the right time horizon are really critical, but there is tremendous potential for impact if you get everybody swimming in the same direction.
Yeah, if I may jump in on that, I will say that I agree with Dawn, the importance of clarity in terms of the targets and the goals that we are achieving. And it has to be something that is co-created. And therefore, I feel the importance also that while we focus on performance, there's also the importance of relationships. And it is critical for us to have a deep understanding of the needs of our patients, as well as the aspiration of our residents.
Yes.
And also at the same time, the needs and aspirations of our partners. Because I think in the new quadruple aim, it's not just about the performance, better care, lower costs, and better health, but also provider satisfaction, the quadruple aim.
Yes.
So I think that is one key element to make and animate population health, because we need to get all parties to come along and share that the desire to perform at what we could in an ideal manner, but based on that relationship, which really makes sense. And this has to be from the senior level at the leadership level, all the way down to the staff on the ground. So for example, between my community nurse that's on the ground with the staff of the senior activity center where they are at. Because sometimes we may agree a lot of things at the senior level, but on the ground, there may be still issues that we need to address. So I think this is something that we have to work on across the board. Thanks.
Thank you, Chien. And I think that's a wonderful concluding statement, I think, for our discussion here today. I'm so impressed by the quality of the questions and the liveliness of the discussion. I think what we're seeing is that capitation and healthier SG is something, I think, as Dawn said, we have to hold hands and jump together. We will never have all the information we need. It's going to change on the ground, but we need to start data first with what we have. We need to be very pragmatic about the commitment and investments that we're going to need in making that actionable. We're going to need plans that are thought out by everyone at the table, recognizing everybody's different strengths, and that the community has assets with respect to reach and knowledge, that the hospital is the right place for the right types of patients, that there will be some people that spend more, there will be some people that gain more. But if we keep our eye on this common prize and value all of the stakeholders, we can move forward. And I think that's really a tremendous message for us. Thank you so much, Chien, and thank you so much, Dan, for being here with us today. Thank you again I know we have many more questions that we could address. This is a conversation that we know will be going on in Singapore for a very long time to come. I really appreciate everyone being here. Thank you so much also to our team at BISI, and it's my great pleasure to close the webinar.